Good afternoon, everyone. I got a couple requests. Number one is, I'm not sure if you guys wanna elaborate more on cardiomyopathy versus congestive heart failure. What was the issue with the cardiomyopathy and congestive heart failure? You just want me to differentiate between both of them? Does anyone remember this issue, this question, concern? So the congestive heart failure is a clinical diagnosis. Congestive heart failure is a clinical diagnosis, and the congestive heart failure definition is when the heart fails to meet the requirements of the body oxygen. In other words, the output of the heart fails to meet the requirements to live in a and a reasonable
Just listening to like this work meeting. Hey,
so fails to meet the requirements of the for oxygenation of the body, and there are certain actually clinical presentations or aspects of clinical presentations from signs of volume overload, low extremity edema, ascites, issues with the physical examination of the lungs, crackles, and so forth, to symptoms such as congestive heart, such as dyspnea and orthopnea and PND and chest discomfort and so forth. So the congestive heart failure is clinical diagnosis. Now we heart failure to two categories: the heart failure with reduced ejection fraction, HFrEF, and heart failure with preserved ejection fraction, HFpEF. And the reason we divide them, because if your ejection fraction below 50%, then the guideline-directed medical therapy is really different than HFpEF, where ejection fraction above 50%. So always remember that the cardiomyopathy is totally different entity. The cardiomyopathy is when you have some kind of insult to the myocardium to let the myocardium not functioning in a reasonable way, and that can be associated with congestive heart failure clinically, or maybe may not be associated with congestive heart failure clinically. And this is why we came up with the classification of class 1 to 4 congestive heart failure symptoms, and we came up with the heart failure also stages from A to D. So it's really totally different entity. And the cardiomyopathy can be non-ischemic cardiomyopathy, idiopathic with decreased ejection fraction, dilated muscle, that could be related to multiple issues, from drug abuse to idiopathic viral infection to alcohol abuse and so forth, or ischemic cardiomyopathy when you have insult to the myocardium because of the coronary artery disease and myocardial infarction, or you have infiltrative cardiomyopathy where you have amyloidosis or sarcoidosis affecting the heart, and hypertrophic cardiomyopathy when you have the congenital heart disease associated with the increased thickness of the septum or the other aspects of the myocardium, and you have decreased in heart function by relaxation issues and diastole and issues with diastole, and what we call the HFpEF associated with it. So if I understood the concern, the congestive heart failure is clinical entity, may or may not be associated with cardiomyopathy, and the cardiomyopathy is insult to the myocardium itself, which can lead eventually to congestive heart failure, but not always associated with congestive heart failure. Any issues with that? So the other question we have is about septal wall motion abnormalities. So remember that when you get electrical conduction to the myocardium, it comes from the bundle of His going and actually uh, the conduction first starts with depolarization of the right side of the septum and then going to the left side of the septum. Um, uh, these kind of conductions most of the time is simultaneous, right? So you get issues with the septal wall motion abnormality when you have either right bundle branch block or left bundle branch block. So the bundle branch block is associated usually with delayed in the conduction and the septum. So if you have right bundle branch block, you're going to have electricity coming from the left side of the septum to the right, and that creates some kind of, quivering in the septum. And if you have left bundle branch block, you're going to have electricity coming initially from the right side of the septum to the left side of the septum. And you really can appreciate that with the echocardiogram. That does not have any prognostic indication beyond the fact that the left bundle branch block has some kind of prognostic indication of worst outcome down the road. We really don't know why, but right bundle branch block is usually benign, left bundle is not benign. So just remember that, and that can create wall motion abnormality now, or septal wall motion abnormality. Now, any kind of open heart surgery and the history of the patient is going to create actually quivering of the septum and wall motion abnormality in the septum without right bundle branch block or left bundle branch block, and that's really benign. The etiology of that is really not understood. And there's the wall motion abnormality of the septum when you have history of myocardial infarction or you have ischemia affecting the wall motion of the heart. And that's going to be as hypokinesis, dyskinesis, or akinesis, which is totally different. And that should be taken into consideration. So wall motion abnormalities in the septum could be related to variety of issues. The bundle branch block usually is not a major concern. A history of open heart surgery, that's not a major concern. But when you have wall motion abnormality in the history of myocardial infarction and history of coronary artery disease, then you have to take that into consideration. Similar to any kind of septal wall motion, or similar to any kind of wall motion abnormality associated with history of myocardial infarction and so forth. Any questions about that?
Yeah, you have a question. Can you unmute her?
Oh yeah, I know that she's muted actually. 1 second, Jack. So Jackie, you can unmute yourself.
Hey, sorry.
No worries.
I was just going to ask, I've been told recently that checking BNP levels in the elderly isn't reliable. Can you expand on that?
Yes, so BNP levels can be, first of all, pro-BNP is much more accurate than BNP. And both of them can be affected, especially BNP can be affected by the Entresto, because as you know, scubitril will actually affect the production of the BNP and actually enhance it. So if you see BNP is elevated in the case, BNP itself elevated in the case of Entresto treatment, that might not reflect CHF exacerbation. But in general, pro-BNP is really elevated in the elderly, and the cutoff usually about 900 to 1,000 based on the age. Remember, BNP is cleared by the kidneys, and acute kidney injury can affect the BNP level. Remember that if you have patient with obesity, the BNP level is not going to be elevated, even though you're going to have congestive heart failure exacerbation or exacerbation of your heart failure. So the way I would deal with BNP, there are a lot of physicians ordering BNP as a baseline and follow congestive heart failure clinically, follow congestive heart failure based on the changes in the BNP level. But BNP level is reasonable in the clinical context of patients. So if you think your patient is having congestive heart failure exacerbation, then BNP elevated, that gonna complement the picture, and in that case, you have to treat accordingly. But if you're having patient, not really having a lot of issues and volume overload is not there, patient is breathing reasonably, and patient has been stable, and BNP is elevated, I would not really treat the BNP, and be careful about that. There are other factors can elevate the BNP. Acute kidney injury can elevate the BNP. History of chronic kidney disease, sepsis can increase your BNP. Sepsis, actually, there's an article a long time ago about sepsis in the British Medical Journal, about sepsis increasing the BNP. Sepsis, ARDS, can increase your BNP. So there are a lot of other factors can increase BNP, and what other aspect I want to talk about when it comes to BNP? Again, the treatment should be, your treatment should be tailored to the clinical context. Oh, yes, if you have COPD, actually what the guidelines like, if you have COPD patient and there's a lot of shortness of breath, you want to figure out if it's because of COPD exacerbation versus congestive heart failure exacerbation, then BNP level is very, very helpful. But otherwise, I would take it in clinical context. And, we really need to get away from the tunnel vision that some of the primary care physicians, some of other practitioners try to deal with. If you have elevated BNP, then you have congestive heart failure exacerbation, and you have to treat with heart failure medications, admit to the hospital, or IV diuretics, or enhanced diuresis, and so forth. I would really caution against that, and I would take it in clinical.
Oh, yeah.
Awesome. Thank you so much.
Any other questions, guys? So, anything else you want to talk about?
You want to touch on pulmonary hypertension?
So pulmonary hypertension, it's now we divide pulmonary hypertension to groups, and I would really, when it comes to pulmonary hypertension treatment, as cardiologist, I would consider treatment of, first of all, the pulmonary hypertension that we care about is the pulmonary hypertension, the secondary pulmonary hypertension, when you have failing left ventricle or cardiac etiology that make it difficult for the right ventricle to work, and from mitral valve stenosis to heart failure with preserved or reduced ejection fraction to atrial fibrillation to aortic valve stenosis and so forth. So anything can affect the cardiac output and make the wedge pressure elevated. That will increase pressure on the right side, and that will create pulmonary hypertension. So for you guys, short of diuresis, I would not really consider treatment of pulmonary hypertension. There are other medications such as prostaglandins and bosentan. We don't really have much data to support good outcome with these medications. Not like, you have somebody with HFrEF and you give Entresto and carvedilol and your mortality is going to come down by 30%. Pulmonary hypertension is not like that. So what I would encourage you guys, if you think that your pulmonary hypertension is related to cardiac etiology, then treat the cardiac etiology itself. Otherwise, you need to leave it to pulmonary people to try to deal with it. And as of now, we really don't have a magic bullet when it comes to pulmonary hypertension treatment. Now, almost everybody after the age of 80 will have certain degree of pulmonary hypertension, and almost 80-90% of these people will have tricuspid regurgitation and probably severe. So in that case, what I would do, I would treat as similar to any heart failure patient and similar to any other cardiac patient with blood pressure control, risk factor modification, fluid management, decreased salt intake, and so forth. But I would not really try to direct treatment to the pulmonary hypertension with vasodilators and so forth. Sildenafil, Viagra did not really work very well. And you have to be careful when you use it, especially when you have somebody with lung disease, because they will enhance actually perfusion to the bad areas of the lungs. and that will decrease oxygen level and create hypoxemia. In fact, me and Steve had a patient, I'm not sure if he's on. We had a patient that we were really convinced that bosentan is going to help pulmonary hypertension. Patient was really on the CPAP for many weeks at Kindred Hospital, and it turned out that the sildenafil, the Viagra, actually was enhancing perfusion to the unhealthy areas of the lungs, and patient was having exacerbation of her hypoxemia. When we stopped, like magically, when we stopped the sildenafil, actually hypoxemia got much better. Granted, patient has severe pulmonary fibrosis and ended up dying, but at least it was learning curve for us. So, short of treating congestive heart failure and cardiac causes of pulmonary hypertension, I would not really do much about pulmonary hypertension, and I would leave most of these treatments to the lung specialists, especially the advanced treatment, the bosentan and the other medications that, really we don't have good data about anything pulmonary hypertension wise. Once you reach the stage of increased pressure on the right side, it's really advanced either lung or cardiac state, and reversing that's going to be extremely difficult. Any other questions? All right. Have a good rest of the day, rest of the week, and happy holidays. Merry Christmas to all of you guys.